All right, let's just dive right into this high-yield explainer. I'm going to be acting as your clinical tutor today to distill some pretty complex streptococcal pathways into exactly what you need to recall for the wards. If you're a medical student looking for the ultimate study guide on this topic, you're in exactly the right place. We're going to rely heavily on clear comparative concepts today to make your review as incredibly efficient as possible. So here's our roadmap for today. 1. Streptococcal classification overview. 2. Managing GS pharyngitis. And 3. A high-stakes head-to-head of strep versus staph toxic shock. All right, Section 1, Streptococcal Classification Overview. We're going to build a rock-solid mental map of how these pathogens group together. Having this framework locked in is honestly half the battle when you're facing board exams or getting pimped on clinical rotations. Looking at the key beta hemolytic groups side by side makes it so much easier to digest. You'll notice penicillin is your absolute workhorse treatment for Group A, also known as S. pyogenes. But then look at Group B, or S. agalactiae. Because Group B is heavily associated with neonatal sepsis and meningitis, we need a specific empiric focus. While penicillin is still the agent of choice, you often have to jump straight to ampicillin plus gentamicin empirically for that neonatal sepsis. Now, Group C and G also respond well to penicillin, though you'll definitely want to consider adding gentamicin if the infection progresses to endocarditis. Okay, real quick, before we leave classification, let's do an active recall check. It's a classic board exam trap. Imagine you're reviewing a patient's blood culture and it grows Group D strep, specifically S. galolyticus, which, used to be known as S. bovis. What is your absolute next mandatory step? If your patient has S. galolyticus endocarditis, a colonoscopy is strictly mandatory. Why? Because this specific organism has a massive, we're talking over 60%, association with colorectal cancer and polyps. It's an incredibly high-yield clinical pearl that examiners literally love to test. You isolate this bug, you book the scope. No questions asked. Moving right along to our alpha hemolytic pathogens. Now, it's super important to keep SBU pneumonia and its classic respiratory targets like pneumonia, meningitis, sinusitis, and otitis media distinctly separate from the verdans group. Both are alpha hemolytic, sure, but their clinical presentations are just vastly different. What's actually kind of cool here is the word origin. Viridans comes from viridis, literally meaning green. And that buzzword, green coloration on agar, is the visual cue you should always associate with subacute bacterial endocarditis. In fact, the viridans group is the most common cause of subacute endocarditis on native heart valves. When you hear green on blood agar, immediately think native valve endocarditis. Oh, and here is a rapid-fire clinical pearl regarding a very specific subset of the viridans group. If you ever see the S. Millery group pop up on a microbiologist report, you need to immediately think of deep tissue abscesses, specifically brain or liver abscesses. Just lock that association into your brain right now. Okay, Section 2, Managing GAS pharyngitis. With those broad classifications locked in, let's pivot and drill down into a super common, highly tested disease state. The real clincher here for differentiating bacterial Group A strep from your run-of-the-mill viral sore throat isn't just the presence of classic symptoms like fever, tonsillar exudate, and tender anterior cervical lymphadenopathy. It's actually the notable absence of viral symptoms. If the patient sitting in front of you has a cough, coryza, or conjunctivitis, you should heavily suspect a virus, not GAS. So what's our diagnostic game plan? Step 1 is always the rapid antigen test. It's incredibly specific, over 95%, which means if it's positive, you trust it and you treat immediately. But don't get caught out by a false negative because the sensitivity is only hovering between 70 and 90%. So if it's negative in a high-risk patient, say someone who's immunocompromised or has a history of rheumatic fever, you must proceed to step 3 and confirm with a culture. Keep in mind, the throat culture is still the absolute gold standard for diagnosis. It's the most sensitive and specific tool we have. But here's the catch. It is entirely dependent on physical technique. You can't just lightly tap the tongue. Getting an accurate result requires vigorous swabbing of both tonsillar pillars. All right, you've got the diagnosis. Treatment typically means penicillin as your first choice. If they've got a non-anaphylactic penicillin allergy, cephalexin or cefadroxil are your go-tos. You can use azithromycin, but definitely avoid it if local resistance is pushing past that 5 to 10% mark. And most importantly, notice that strict 10-day duration. That duration is completely non-negotiable, regardless of the agent you're using, because cutting it short fails to prevent our next major complication. This is a classic point of confusion that gets tested all the time. Completing that full antibiotic course completely saves the heart by preventing acute rheumatic fever, or ARF. But, and this is a big but, it absolutely does not protect the kidneys. Penicillin will not prevent post-streptococcal glomerulonephritis. Let's test your clinical judgment for a second with a quick scenario. Imagine your rapid test comes back positive for group A strep, but the patient sitting right in front of you has zero symptoms. They feel totally fine. What's your next move? Do you hand them a 10-day course of penicillin? The answer? You hold off. No routine treatment. Asymptomatic carriers just have a way lower risk of developing acute rheumatic fever and a much lower risk of transmitting the bacteria compared to someone with actual symptomatic pharyngitis. So routine treatment isn't recommended unless they're actively transmitting it to others, like in a tight household outbreak. And hey, if you do need to eradicate the carriage, you'd actually use cephalexin or clindamycin for 10 days, instead of standard penicillin. Moving into our final stretch, Section 3, Strep versus Staph toxic shock. We are going to pit two incredibly dangerous, very similar sounding syndromes against each other, so you literally never mix them up on the wards. I really want this number etched right into your memory. 30% or greater. That is the alarming mortality rate for streptococcal toxic shock syndrome. This is a medical emergency of the absolute highest order. When we compare the clinical origins here, you see some major differences. Strep TSS, caused by S. pyogenes, usually stems from really severe, deep tissue infections. We're talking necrotizing fasciitis, myositis, severe cellulitis. On the flip side, Staph TSS, caused by S. aureus, is classically linked to things like tampon use, surgical wounds, or nasal packing. Also, pay attention to the rash. It's highly variable or even absent in Strep TSS, but Staph TSS gives you that classic diffuse erythematous rash with desquamation of the palms and soles. Now here is the ultimate differentiating factor you absolutely must memorize. Strep gets into the bloodstream. The vast majority of Strep TSS patients are profoundly bacteremic. Staph, however, is a completely different story. In Staph TSS, bacteremia is highly uncommon. It happens in less than 15% of cases. The Staph bacteria basically stays localized while just pumping out those TSST1 superantigen toxins systemically. So how do we treat it? Because Strep TSS involves pyrogenic exotoxins acting as superantigens, your standard antibiotics just aren't going to cut it. Penicillin is there to kill the bug, sure, but you must add clindamycin. Why? Because clindamycin specifically goes in and shuts down the production of those deadly pyrogenic exotoxins right at the ribosomal level. It's a game changer. You might also need IVIG. And listen, if necrotizing fasciitis is the source, immediate surgical debridement is absolutely mandatory. The stakes here literally couldn't be higher. Getting this diagnosis and treatment protocol wrong means your patient is facing that brutal 30% mortality rate with Strep TSS, compared to a much more manageable 5% rate for treated Staph TSS. You really have to know your pathogens. As we wrap up this explainer, I want to leave you with something to really ponder on your next shift. Given the sheer, devastating speed of these superantigen toxin-mediated diseases, are our current diagnostic tools and culture turnaround times evolving fast enough to beat the rapid progression of these bacterial toxins? It is quite literally a race against time, and your sharp clinical knowledge is the best head start your patient has. Thanks for joining me for this study session. Keep those comparative tables handy, and I'll catch you in the next explainer.